Welcome everyone. Thank you for joining the NAS Provider Video Series. This series of 4 videos was developed to increase awareness and understanding of adverse childhood experiences, prenatal substance exposure, medication-assisted treatment, and the impact on infants and their families. The development of this public education series is the result of collaboration between state agencies and community partners. This program is presented by Tara Sundam, co-founder and owner of Hushabye Nursery, and examines how to care for an infant suffering from neonatal abstinence syndrome, or NAS, and the substance-exposed newborn, or SEN. Any substance used by a pregnant mother may have harmful effects on her developing infant, including the use of tobacco, alcohol, marijuana, heroin, opioids, benzodiazepines, and any combination of these drugs or herbal remedies. This presentation describes the effects of substance use on the infant, assessment and treatment in the hospital, and demonstrates techniques useful to soothe and comfort infants struggling with substance withdrawal.
Every day, more than 2 babies are born in Arizona with suspected substance-related withdrawal symptoms. I'm Tara Sundam. I'm co-founder of Hushabye Nursery. I'm also a neonatal nurse practitioner that has worked in the Valley for over 25 years. I take care of sick babies for a living. Neonatal abstinence syndrome occurs when a mom's been taking substances, most commonly opiates. They pass through the placenta to the baby, and when the umbilical cord is clamped, the baby's not receiving that opiate anymore. They start withdrawing and showing signs and symptoms very similar to what an adult does. You're going to see neonatal abstinence syndrome and neonatal opioid withdrawal syndrome being used interchangeably in the community. The difference is neonatal abstinence syndrome is any constellation of withdrawal symptoms occurring by multiple substances. So opiates including SSRIs or benzodiazepines. NAS is specifically opiate withdrawal. Neonatal abstinence syndrome is the diagnosis code that we're using in the hospital right now. This slide depicts what's going on in the baby when you see the withdrawal signs. So what's going on with your dopamine and your serotonin, your norepinephrine. This is what's happening that's showing the constellation of the withdrawal symptoms. The symptoms that we see in a baby are very similar to what an adult experiences. I had one mom explain to me that withdrawal was like having the worst flu and migraine times 100. Another one told me you literally want to die. When you see these babies, it appears painful. You're going to see mottled skin. They're going to sneeze a lot. Usually 3 or more sneezes is a red flag. They yawn, they shake, vomiting and diarrhea. Probably the most common withdrawal symptom that we see is GI upset. The worst symptom would be seizures, and that's what we're trying to avoid. This is a slide showing the modeling of the skin, the excoriation of the face and limbs. You'll see it on the knees and the elbows, and most commonly to the booty. They'll have horrible diaper rashes. I always encourage families to make sure that we're putting the Desitin and the Aquaphor as a barrier before a diaper rash becomes an issue. The hypertonicity is probably one of the more common signs that you're going to see. Babies are going to start tremoring, they're going to sneeze, and then that hypertonicity, you're going to barely be able to move their legs down to change their diaper. The causes of withdrawal, any substance that a mom takes goes to her baby. So if we notice that we don't have caffeine and you get a headache later on in the afternoon, babies are going to notice those signs and symptoms if we are, exposing them to a lot of different substances. So it's not uncommon for a mom to be a heavy smoker and she's been in labor for 24 hours, she hasn't had a cigarette, and baby comes out shaking, showing those tremors. If she has opiate use disorder, we a lot of times think that, oh my gosh, baby's already withdrawing from that, when really maybe it's the nicotine that baby is withdrawing from, because it's been 24 hours without any substance. A new substance that we're seeing in an herbal remedy is kratom. So really changing the way that we interview and get the information from families as far as what prescribed substance are you taking, are you smoking, and any other herbal supplements is really what we should be making sure that we're asking. Causes of true neonatal abstinence syndrome or neonatal opioid withdrawal syndrome that the American Academy of Pediatrics is telling us to change our treatment is with the opiates. So any babies that are exposed to Percocets, your painkillers, heroin, fentanyl, those would be the babies that the AAP now tells us that we should be watching for a minimum of 5 days here in the state of Arizona, well, here in our NICUs. They should be watched for an extended period of time. The SSRIs and the benzodiazepines, babies are definitely going to withdraw, but that is not a recommendation by the American Academy of Pediatrics to keep them in the hospital for a longer time. We will see some substances that may have neonatal abstinence syndrome symptoms with cocaine, crack, methamphetamine, speed, and ecstasy, but it is not a recommended reason for watching more closely. Meth. When we talk about meth, you really need to clarify with our families, with our nurses, is it methamphetamine or methadone? Methamphetamine, we're not going to watch for 5 to 7 days. Methadone, we need to watch for 5 to 7 days. Methadone is the treatment of choice for a mom that finds herself pregnant and has opiate use disorder. So methadone is what we want to see, and actually it tells us that moms are in recovery. Factors that are going to increase the severity of neonatal abstinence syndrome. The babies that are bigger, so the babies that are term, we see more signs and symptoms. Is that because the baby's neurological symptom or nervous system is more developed? Definitely could be. We just know that they show more symptoms. The polysubstance, smoking, a lot of times we believe that there probably is a genetic factor, that studies are being shown on that. And things that decrease the signs and symptoms, number one, biological parents. And number two, breastfeeding. Less than 0.0002% of methadone or Subutex gets transported from the mom through the breast milk. So we really think that breastfeeding, the reason that it actually is tolerated and helps the baby withdraw easier is probably the bonding experience and the fact that breast milk is easier to digest than our formulas. There's 2 different assessment tools that we look at when we're watching babies withdraw and trying to figure out when do we need to administer a pharmacological treatment. The newest one is the Eat, Sleep, and Console model, the ESC. That only looks at 3 different factors. Can the baby eat an ounce? Does the baby sleep for an hour? And can the baby be consoled within 20 minutes? If those can be done, baby's doing good, and we continue just doing non-pharmacological treatment. If you can't, then usually we give 1 dose of morphine at 0.05 milligrams per kilo and see how they do. Now you have the modified Finnegan system, which is more difficult. It's 21 different withdrawal symptoms that you're looking at. It's very subjective. Eat, Sleep, and Console can be subjective, but the modified Finnegan can be. Once your score is greater than 8, that's a red flag to us saying, okay, baby's realizing that they're not getting this opiate anymore. If you have 3 scores that equal greater than 24, by most guidelines, we start morphine at 0.05 per kilo, and usually every 3 hours. Once we're stabilized and those scores are less than 8 again, you're going to see us start to wean the babies, usually every 24 to 48 hours, usually by 10 to 20% every day. Maternal opioid use disorder treatment, why do we not go cold turkey? It puts them at a higher risk for miscarriage. Babies experience the same withdrawal symptoms as an adult. And when you talk to an adult, withdrawal is awful. So the mom's withdrawing and babies withdrawing inside mom. So miscarriage is a biggie. The treatment of choice and the gold standard, according to the obstetrical community, is to start mom on medication-assisted treatment. So you're going to see methadone or Subutex being started. Management of neonatal abstinence syndrome, that is not pharmacologic. Biological parents, number 1. Breastfeeding, number 2. Quiet, dark environment. So any environment that is not the neonatal intensive care unit would be ideal for these babies. Doing a squatting motion versus the patting of the butt. Really, babies tolerate swaddling them with their hands to their face and giving them the pacifier. The only way that babies can self-soothe is their hands to their face and them sucking on the pacifier or sucking. So really allowing that is what we need to do. Avoid rubbing and stroking them, and then also explain to the families that there really is such a thing as third-hand smoke. So if they're smokers, encouraging them when they come back in after smoking outside, that they change their clothes before they hold their baby. Nutrition. GI upset is one of the most common withdrawal signs. So small frequent feedings, not our every 3-hour feedings that we always do in our neonatal intensive care units. Warming the formula, changing their formulas to a more simple formula, Similac sensitive, gentle ease, elemental formulas if needed. Just being aware that feeding intolerance can be just a withdrawal sign. Not necessarily are we going to be able to take away that feeding intolerance without sometimes having to give an opioid because they're just having such a hard time withdrawing. As I'd said previously, the morphine, when we start it, it's your opioid replacement. We start at 0.05 milligrams per kilo, usually every 3 hours. Sometimes people are doing 1 dose and seeing how it does. Methadone is being used throughout the country at different places. We're not there yet here in Arizona, but it does have a longer half-life. And then clonidine and phenobarbital. Once the dose of morphine doesn't seem like it's doing the trick, a lot of times adding on clonidine or phenobarbital. In my experience, phenobarbital being added on when a baby is exposed to poly substances seems like those little ones do better. Phenobarbital, once you start them on it though, they're going to go home on that dose and they're going to need to outgrow their dose at home. Management of neonatal abstinence syndrome. What if we started prenatally? What if we congratulated these families and encouraged them to get the prenatal care that we want? Going to the obstetrician, making sure that they're connected with the prenatal classes, making sure that they understand that they can't smoke weed, that DCS is going to be involved, that these are the withdrawal signs and symptoms that their baby is going to experience and when they're going to happen, and teach them how to make it better. Making sure that they understand skin to skin, that kangaroo care, to decrease the lighting in the room, to shut off their phones. All of that should be done prenatally. Recommended discharge follow-up. Early intervention is key. We need to make sure that the delays and deficits are found as quickly as possible. So the pediatrician alone is not enough. We need to make sure that we're getting the developmental specialists, identifying if they need occupational therapy, speech therapy, physical therapy, getting the home visitors in the house to make sure that these families are getting what they need is what is definitely required. And then trying to hook these families up with the support groups that are out there. These families are very isolated. Trying to help them build their village is a huge goal, and we really should try to accomplish that.
So withdrawal is really hard. There's a few things that can make withdrawal just a little bit easier. Number one, their parents, biological, mom and dad being present. That's what you want. Number two, babies being able to breastfeed. So if it is not contraindicated, really babies need to breastfeed, and we need to encourage these mamas to do so. The other things that we can do that can make it just a little bit easier, I'm going to show. So usually with a baby, a regular baby that's not having trouble with withdrawal, we hold them face to face, we bounce them, we do this pat, pat, pat. Remember that these little ones are really hypersensitive. So turning down the lights, shutting off the TV and the computer, wrapping them very tightly. Remember, these little ones have tummy aches. Withdrawal, one of the main symptoms of withdrawal is GI upset. So when you wrap them, you need to make them very tight. We're going to act like this is a baseball field. You have first, second, third base. You wrap down second base to the pitcher's mound. You're going to position the baby about an inch below that. Make sure you put your hands to your face. Take first base all the way around and wrap it up behind their booty. Knees to their chest because they have tummy aches. Take home plate and put it up and over that shoulder. Take third base and wrap it around for that home run. So you have them bundled like a little burrito. Now, sometimes this face-to-face movement is too much for these little ones. That's hypersensitive. They cannot tolerate that. I know that we want to coo and caw, but this is actually one of the hardest things for a baby to do. So sometimes when they're having the hardest time and you've fed them, you've changed them, you know that that is not the answer. You've wrapped them, bundled them. More than likely they have a tummy ache and they're just experiencing horrible withdrawals. All of these little ones, no matter what, get a pacifier. So when you have that family that says, no, we don't want them to have a pacifier, the only way babies can self-soothe, hands to their face and sucking. We have to let them have that opportunity. So sometimes turning them away from you, you've turned down the lights, you've shut off all the electronics, holding their knees to their chest. They're going to kick away from you because they have that tummy ache. First thing that a baby does is they go straight. You're going to hold their knees to their chest and they're going to push. And you're going to start doing what we call this squat, up and down motion. And when you're doing that, then you're going to do the shh, 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 shh. What that shush is that's mimicking mom's heartbeat. As you're getting tired with your legs, because you are doing that squat, go up on your heels and continue that. Now, as you've done that, you remember you've changed their diaper, they've been fed. Usually when you do the squat, they're going to give you that great big burp that they haven't been able to do because they finally have relaxed enough. As you get tired, if you can realize that truly you're starting to get anxious. So just pause for a second, take that deep yoga breath, and I want you to do 3 of them. So, and hold it in and let go. Since I've been doing this, I haven't had one baby that doesn't stop and look at me like, what in the world did you just do? By the time that I've done 3 of those deep yoga breaths, I've not only decompressed my anxiety, I've interrupted their fit 3 times. Then you go back to holding a pacifier in their mouth, you're holding their knees to their chest, you're holding them tightly, and you're going up and down. Shh, 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 shh. Remember, all stimuli, as much as you can, you need to decrease. Usually, these things work. Teaching families how to do these are even more effective.